Welcome to Night Shift Pulse. Comment your city and the time below. The night connects us all. If you enjoy what you hear, please subscribe. Let's step into the dark. Story 1. The voluntary admission that never processed. I remember standing at the intake desk watching the nurse's pen move across the consent form. My hands were steady. My voice was calm. I told her I needed help, and I meant it. That clarity felt like a gift after weeks of unraveling thoughts and sleepless nights. The fluorescent lights hummed overhead, casting everything in that particular shade of institutional white that feels both sterile and safe. She smiled, professionally, distantly, and slid the clipboard toward me. I signed my name 4 times, once for admission, once for treatment consent, once for privacy acknowledgement, once for the patient rights documentation. Each signature felt like a small act of recovery. The ward was exactly what I expected, linoleum floors polished to a dull gleam. Bulletin boards covered in activity schedules written in optimistic pastel markers. A television mounted high on the wall in the common room, always tuned to nature documentaries with the sound turned low. My room was small but clean, a bed with a vinyl mattress, a desk bolted to the wall, a window with reinforced glass that looked out onto a courtyard where no one ever seemed to go. I was assigned to Unit 7B, second floor, East Wing. My wristband said my name, my date of birth, and a patient identification number, 63219. I checked it several times that first day just to make sure it was real. The first 48 hours passed in a haze of assessments. A psychiatrist with tired eyes asked me about my sleep patterns, my appetite, my reasons for coming in. I answered honestly. A social worker reviewed my insurance information and asked about my support system. I gave her the names of 2 friends I trusted. A nurse took my vital signs every 4 hours and noted them on a laminated chart clipped to the end of my bed. Everything felt procedural, methodical, and reassuring in its predictability. I attended group therapy sessions where other patients spoke in halting sentences about their own struggles. I nodded when appropriate. I did not share much, but I listened. At night, I slept better than I had in months. On the 3rd day, I asked the morning nurse when I might meet with the treatment team to discuss my progress. She glanced at her tablet, scrolled for a moment, then frowned. She told me she would check with the charge nurse. I did not think much of it. Institutions move slowly. I had expected that. But by the afternoon, when the charge nurse came to my room, her expression was different. She asked me to confirm my name, my date of birth, and my identification number. I repeated them. She looked at her tablet again, then at me, then back at the screen. She told me there was a discrepancy in the system and that she would need to verify my intake paperwork. I asked what kind of discrepancy. She did not answer directly. She said something about digital records and manual logs not aligning. She said it happened sometimes, especially with voluntary admissions processed over the weekend. I told her I had been admitted on a Thursday. She made a note on her tablet and left. That evening, I went to the nurse's station and asked to speak with the intake coordinator. The nurse on duty told me the coordinator only worked weekdays and that I would have to wait until Monday. I said that was fine. I returned to my room and tried to read a magazine someone had left in the common area. The pages were all stuck together from humidity or repeated handling. I gave up after a few minutes and stared out the window instead. The courtyard was empty. It was always empty. Monday came. I approached the nurse's station again and asked if the intake coordinator was available. A different nurse, younger, with her hair pulled into a tight bun, looked up from her computer. She asked for my name. I gave it. She typed for a moment, then shook her head. She told me there was no appointment scheduled. I explained that I had been told to follow up about a discrepancy in my intake records. She typed again. She said she could not find my intake records. I felt something cold settle in my chest. I asked her to check again. She did. She pulled up several screens, scrolling through what I assumed were patient lists and admission logs. After a long silence, she told me that according to the system, I had not been admitted to Unit 7B. I pointed to my wristband. I reminded her that I had been on the ward for 5 days. She looked at the wristband, then at her screen, then at me. She said she would escalate the issue to the unit supervisor. The supervisor arrived an hour later. She was older, with deep lines around her eyes and a calm, measured voice. She brought me into a small conference room off the main hallway and closed the door. She asked me to describe my admission process in detail. I did. I told her about the intake desk, the consent forms, the signatures, the assessments. She took notes on a yellow legal pad. When I finished, she set her pen down and folded her hands. She told me that there was no record of my voluntary admission. She said that the system showed my bed as unoccupied. She said that the identification number on my wristband did not correspond to any active patient file. I asked her how that was possible. She said she did not know. She asked if I had brought any documentation with me, a referral letter, a copy of the intake forms, anything. I told her I had not. She said she would continue investigating. She asked me to be patient. Days continued to pass. I attended therapy groups. I took my medications, small paper cups delivered twice daily with water in plastic tumblers. I participated in recreational activities. I ate meals in the cafeteria. Staff interacted with me normally as if I belonged there. But whenever I asked about my intake paperwork or my discharge plan, I was met with the same response. They were still looking into it. They were still trying to resolve the discrepancy. They would update me as soon as they had more information. I started keeping track of time more carefully. I marked days on the back of a napkin I kept folded in my pocket. 1 week became 2. 2 became 3. I asked other patients if they had experienced similar issues. Most looked at me with confusion or disinterest. One woman, older, with silver hair and a habit of pacing the length of the hallway, told me that she had been waiting for her discharge paperwork for 6 months. She said the system was broken. She said we were all caught in it. I requested a meeting with my psychiatrist. When we finally sat down together, I explained everything. I told him I had admitted myself voluntarily, that I had signed every required document, that I had cooperated fully with treatment. I told him that my intake records could not be located, and that I was being told I had never formally arrived. He listened without interrupting. When I finished, he leaned back in his chair and asked me if I remembered why I had sought admission. I told him I did. He asked me to describe my state of mind at the time. I did. He made notes. Then he asked if I had considered the possibility that my memory of the intake process might be unreliable. I stared at him. I asked him if he was suggesting I had imagined signing the forms. He said he was not suggesting anything. He said he was exploring all possibilities. He said that confusion and disorientation were common symptoms, particularly in the early stages of treatment. I told him I was not confused. I told him I remembered everything clearly. He nodded and made another note. He told me we would continue to monitor my progress. I stopped asking about discharge after that. It seemed pointless. The ward had become a kind of limbo, a place where time moved but nothing changed. I woke each morning to the same fluorescent lights. I attended the same group sessions. I ate the same rotating menu of meals. My name was called during medication rounds. My vital signs were recorded on schedule. But according to the system, I did not exist. According to the records, I had never chosen to be there at all. At night, I lay in my bed and stared at the ceiling. I thought about the forms I had signed. I thought about the nurse's pen moving across the paper. I thought about my wristband and the identification number printed on it. I wondered if somewhere in some filing cabinet or database those documents still existed, or if they had been erased, or if they had never been created in the first place. I wondered if voluntary admission required proof, or if belief was enough, and whether in the end, the difference even mattered. Story 2. The observation patient on constant watch. The psychiatrist explained the protocol during my second day on the ward. Continuous observation, she said, was a standard safety measure for patients considered at elevated risk. She did not elaborate on what specific risk I posed, and I did not ask. I understood the concept. Someone would be assigned to monitor me at all times. They would document my behavior, my mood, my interactions. The goal was to ensure I remained stable, that I did not harm myself or others. It sounded reasonable, clinical. I signed the consent form they placed in front of me and tried to feel grateful for the attention. The observation began immediately. A young man in scrubs, tall, with a name badge that read Aaron, positioned himself in a chair just outside my room. He carried a clipboard with lined paper and a black pen that he clicked rhythmically against his knee. I asked him if he needed anything. He smiled politely and shook his head. He said he was just there to keep me company. I returned to my bed and tried to read a book I had brought from home. Every few minutes I glanced toward the door. He was always there watching. Writing. The scratching of his pen became a kind of ambient noise, constant and oddly soothing. The shifts changed every 8 hours. Aaron was replaced by a woman named Jessica, who sat in the same chair and held the same clipboard. She was quieter, more reserved. She barely looked at me, but I could hear her pen moving across the paper in steady, measured strokes. I wondered what there was to document. I had done nothing. I had sat on my bed, flipped through my book, stared at the wall, but she wrote continuously, filling page after page. At one point, I got up to use the small bathroom attached to my room. When I emerged, she was writing again. I asked her what she was noting. She said it was just routine documentation. She said I should not worry about it. The third observer was an older man named Calvin. He had gray hair and deep-set eyes that gave him a look of perpetual exhaustion. He did not speak to me at all. He simply sat, observed, and wrote. I tried to ignore him. I tried to pretend the chair outside my door was empty, but the presence was impossible to dismiss. I felt watched in a way that went beyond supervision. It was as though every breath, every shift in posture, every flicker of thought was being recorded and analyzed. On the fourth day, I asked to see the observation log. The request was met with hesitation. The nurse on duty, a woman with short blonde hair and a brisk manner, told me that the log was part of my medical record and that I could request a copy through the proper channels. I asked if I could at least know what was being documented. She said the observers were trained to note any behaviors relevant to my treatment plan. She said it was nothing to be concerned about. I pressed further. I asked for specifics. She said she could not discuss the details without my psychiatrist present. I did not push, but the unease settled deeper. That night I found it difficult to sleep. The observer stationed outside my door was a woman I had not seen before. She was younger than the others, with dark hair pulled into a ponytail. She did not write as frequently. Instead, she watched. Her eyes followed me as I shifted beneath the thin blanket, as I turned toward the wall, as I stared at the ceiling. I closed my eyes and tried to force myself into unconsciousness, but I could feel her gaze. It was a tangible thing, a weight pressing against my awareness. When I woke the next morning, I felt exhausted. The observer had changed again. This time it was a man named Derek who greeted me with a curt nod and resumed his position in the chair. I asked him how long he had been there. He glanced at his watch and told me since 6 in the morning. It was now 8:30. I asked if the previous observer had left any notes for him. He said he had reviewed the log before his shift. I asked what it said. He hesitated, then told me he was not authorized to discuss it. I requested a meeting with my psychiatrist. It took 2 days to schedule. When we finally sat down together in one of the small consultation rooms, I told her I wanted to see the observation log. I explained that I felt uncomfortable not knowing what was being written about me. She nodded thoughtfully and said she understood my concern. She opened a folder on the desk between us and pulled out a stack of papers. She told me she could share some highlights, but that the full log was quite extensive. I told her that was fine. I just wanted to know what behaviors had been documented. She flipped through the pages, her expression neutral. Then she began to read. She said that on the first night I had been observed pacing my room between the hours of 11 p.m. and 2 in the morning. I told her I had not paced. I had been in bed the entire night. She made a note and continued. She said that on the second day I had engaged in a prolonged conversation with another patient, during which I had made statements that suggested confusion about my surroundings. I asked who the other patient was. She said the log did not specify. I told her I had not spoken to anyone that day. She made another note. She continued reading. The entries described behaviors I did not recognize: outbursts of anger during group therapy, refusal to take medication, episodes of dissociation during recreational activities. I interrupted her. I told her that none of those things had happened. I told her I had attended every session, taken every pill, participated in every activity without incident. She looked at me with an expression that was difficult to interpret. She said that sometimes patients were not fully aware of their own behaviors. She said that stress and illness could distort perception. I told her my perception was fine. She closed the folder and said we would continue to monitor the situation. I returned to my room feeling unmoored. The observer that afternoon was a woman named Linda, who sat with her legs crossed and her clipboard balanced on her knee. I asked her directly if she had witnessed me pacing, yelling, or refusing medication. She looked at me with mild surprise and said she had only been assigned to me for this shift. I asked if she could check the log from previous shifts. She said the log was confidential. I told her I had just reviewed parts of it with my psychiatrist. She said she still could not discuss it. The days blurred together. The observers rotated, their faces becoming interchangeable. The log continued to grow. I began to dread the meetings with my psychiatrist, during which she would read entries that described a version of me I did not recognize. I tried to argue, I tried to provide counter-evidence, but there was nothing to counter. The log was official. The observers were trained professionals. My word was just that, my word. And in a psychiatric ward, the word of the patient carries little weight. I started watching the observers more carefully. I noticed that some of them wrote even when I was completely still, even when I was asleep. I noticed that the entries were time-stamped with precision, down to the minute. I began to suspect that the log was not a record of my behavior, but a script, a predetermined narrative that the observers were filling in, regardless of what I actually did. One evening, I confronted the observer on duty. His name was Marcus, and he had a calm, almost robotic demeanor. I asked him if he was writing down things that had not happened. He looked at me without expression and said he only documented what he observed. I asked him what he had observed in the last hour. He glanced at his clipboard and read aloud. He said I had exhibited signs of agitation, including repeated questioning of staff and refusal to engage in scheduled activities. I told him I had been sitting on my bed reading for the entire hour. He said that was his observation. I asked him how his observation could be so different from reality. He did not answer. That night I lay awake and listened to the sound of the pen scratching against paper. The observer was writing continuously, filling page after page. I wondered who would read those pages. I wondered what decisions would be made based on them. I wondered if I was being documented into a role I had never agreed to play. The next morning, during a group therapy session, the facilitator asked how everyone was feeling. I said I was confused. I said I felt like I was being described as someone I was not. The facilitator asked me to elaborate. I explained the observation log, the discrepancies, the behaviors I had not performed. She nodded sympathetically and said that sometimes our self-perception did not align with how others saw us. She said that therapy was about bridging that gap. I said it was not about perception. I said it was about documentation. She moved on to the next patient. I requested another meeting with my psychiatrist. This time she seemed less patient. She told me that the observation log was a clinical tool, not a personal attack. She said that the observers were trained to be objective. She said that if I continued to fixate on the documentation, it would interfere with my treatment. I asked her why the log described behaviors that contradicted my own memory. She said that memory was not always reliable. She said that denial was a common defense mechanism. I told her I was not in denial. She said we would revisit the topic in our next session. I stopped asking questions after that. I let the observers sit outside my door. I let them write whatever they wanted. I attended my sessions, took my medications, and participated in the daily routine. But at night, when the ward was quiet and the only sound was the scratching of the pen, I lay awake and thought about the log. I thought about the version of me that existed in those pages. I thought about the patient they were describing, the one who paced, who yelled, who refused help. I thought about how that patient would be treated, what interventions would be recommended, what restrictions would be imposed. And I realized slowly that the observation was not about monitoring me. It was about creating me. The log was not a reflection of my behavior. It was a blueprint. The observers were not documenting a patient. They were writing one into existence. And with each shift, each entry, each time-stamped note, that patient became more real, more official, more permanent. I wondered how long it would take before the patient in the log replaced the person I believed myself to be. I wondered if it already had. And I wondered if anyone would notice the difference. Or if in the end, the log was the only version of me that mattered. Story 3. The high-risk intake assigned my room. The room reassignment happened without warning. I returned from a group therapy session to find my belongings. A small duffel bag, a toothbrush, a paperback novel, stacked neatly outside a different door. The nurse on duty, a woman named Brenda with tired eyes and a methodical way of speaking, explained that there had been a scheduling conflict. She said my original room was needed for a high-priority intake. She said I was being moved to room 12C just down the hall. I asked why I had not been notified in advance. She said the decision had been made quickly. She said it was for the best. Room 12C was nearly identical to my previous room. Same narrow bed, same bolted desk, same reinforced window overlooking the same empty courtyard. The only difference was the location, closer to the nurse's station, closer to the medication dispensary, closer to the locked door that separated the unit from the rest of the hospital. I unpacked my belongings and tried to settle in. The walls were the same shade of institutional beige. The air smelled faintly of disinfectant and something else I could not quite identify. I told myself it did not matter. A room was a room. The first indication that something was different came during the evening medication round. A nurse I had not seen before, young with a nervous energy and a habit of checking his tablet twice before speaking, knocked on my door and entered with a small paper cup. He handed it to me and waited while I swallowed the pills. Then he asked if I understood the additional safety protocols. I looked at him, confused. I asked what protocols he meant. He glanced at his tablet again, scrolling quickly, then said that all high-risk patients were required to check in verbally after taking their medication. He said I needed to confirm that I had swallowed the pills and that I had no intention of self-harm. I told him I had swallowed the pills. He made a note and left. I assumed it was a misunderstanding. Perhaps the room change had caused some confusion in the system. Perhaps my file had been mislabeled. I mentioned it to Brenda the next morning. She frowned and said she would look into it. But that afternoon during recreational therapy, a staff member pulled me aside and reminded me that I was not permitted to use any equipment without supervision. I asked what equipment she meant. She gestured toward the art supplies laid out on a table: blunt scissors, washable markers, construction paper. She said that high-risk patients were restricted from items that could be used for self-harm. I told her there must be a mistake. She said she was following the guidelines in my chart. I requested to see my chart. The request took 3 days to process. When I was finally allowed to review it, I sat in a small conference room with a patient advocate, a soft-spoken man in his 50s with wire-rimmed glasses and a legal pad. He opened a thick folder and began walking me through the contents: intake forms, assessment notes, treatment plans. Everything looked standard until he reached a section labeled Risk Assessment. He paused, then read aloud. The document classified me as a high-risk patient with specific notations about potential self-harm and violent ideation. I interrupted him. I told him that was incorrect. I told him I had never expressed any intent to harm myself or anyone else. He looked at the document again, then at me. He said the assessment had been completed during my intake. I told him I did not remember being asked those questions. He said the assessment was mandatory. He said it could not be skipped. I asked to speak with the person who had conducted the assessment. The advocate said that information was not listed in the file. He said he could submit a request for clarification, but it would take time. I asked how long. He said he could not give me a specific timeline. I left the meeting feeling more unsettled than before. The safety protocols intensified. I was required to check in with staff every 2 hours, confirming my location and my emotional state. My door was no longer allowed to close fully. It had to remain propped open with a rubber wedge so that staff could observe me at all times. During group therapy, I was seated closest to the facilitator in a chair that faced away from the windows. When I asked why, the facilitator said it was a precaution. She said it was nothing personal. Other patients began to notice. During meals in the cafeteria, I was seated at a table near the staff observation area. A man across from me, middle-aged with a graying beard, asked why I was under such close watch. I told him I did not know. He said I must have done something serious. I told him I had not. He shrugged and said the staff did not usually make mistakes. I started finding evidence of interventions I had not experienced. A restraint log left briefly on the counter at the nurse's station included an entry with my name. It described an incident in which I had become agitated during a therapy session and required physical de-escalation. I read the entry 3 times, trying to reconcile it with my memory. I had attended every therapy session without incident. I had never been restrained. I had never been agitated to the point of requiring intervention. I asked the nurse on duty about the entry. She glanced at the log, then at me. She said the log was confidential. She said I would need to discuss it with my treatment team. The treatment team meeting was held a week later. My psychiatrist, the unit supervisor, a social worker, and 2 nurses sat around a table in a windowless room. I was invited to sit at the far end. The psychiatrist began by reviewing my progress. She said I had been cooperative with treatment. She said I had not exhibited any overt signs of distress. Then she said that despite my outward stability, the risk assessment indicated a need for continued high-level monitoring. I asked her to explain the assessment. She said it was based on my intake interview, my behavioral history, and clinical judgment. I told her I did not have a behavioral history that warranted high-risk classification. She said that sometimes patients were not fully aware of the risks they posed. She said the assessment was precautionary. I asked about the restraint log. The room went silent. The social worker glanced at the psychiatrist. The psychiatrist glanced at the supervisor. Finally, the supervisor said that the log documented interventions that had been deemed necessary at the time. I asked when the intervention had occurred. She said she would need to verify the date. I told her I had no memory of being restrained. She said that was not uncommon. She said that patients often did not remember interventions that occurred during periods of acute distress. I told her I had not experienced acute distress. She made a note. The meeting ended without resolution. I returned to room 12C and lay on the bed staring at the ceiling. The door was propped open. I could hear the nurses stationed down the hall, the murmur of voices, the beeping of monitors, the occasional burst of laughter. I wondered if the high-risk patient they were preparing for had ever arrived. I wondered if the room had been reassigned because that patient was me. Over the following days, I noticed new additions to my room, a padded mat beneath the bed, a plastic cover over the light fixture, a second rubber wedge to prevent the door from closing even partially. I asked a staff member why these changes were being made. She said they were standard for high-risk patients. I told her I was not high-risk. She said the chart indicated otherwise. I began to dread the routine checks. Every 2 hours, a staff member would appear at my door and ask how I was feeling. I would say I was fine. They would ask if I had any thoughts of self-harm. I would say no. They would make a note and leave. The questions became a script. The answers became automatic. But the repetition itself felt like evidence. Each check reinforced the idea that I was someone who needed checking. Each question suggested that the thoughts they were asking about might eventually materialize. One evening, I overheard a conversation at the nurses' station. 2 staff members were discussing the upcoming shift change. One of them mentioned my name. She said I had been surprisingly stable. She said she had expected more incidents by now. The other staff member said that sometimes the high-risk patients were the quietest. She said they were the ones you had to watch most carefully. I returned to my room and sat on the edge of the bed. I thought about the restraints that had been prepared but never used. I thought about the assessment that classified me as dangerous before I had done anything dangerous. I thought about the room reassignment, the protocols, the logs. I thought about the version of me that existed in the chart, the high-risk intake who posed a threat, who required constant supervision, who could not be trusted with blunt scissors or closed doors. And I realized that the room had not been reassigned because of a scheduling conflict. It had been reassigned because the high-risk patient had always been expected. The protocols had been prepared in advance. The interventions had been documented before they occurred. The only thing missing was the patient himself. And I was the one who had been moved into his place. Story 4. The long-term resident cleared for release. The psychiatrist delivered the news during a routine session. She said my progress had been consistent, my symptoms well managed, my engagement with treatment exemplary. She said the treatment team had reviewed my case and agreed that I was ready for discharge. She said the paperwork would be processed within the next few days. I remember the relief that washed over me, a physical sensation, like a weight lifting from my chest. I thanked her. She smiled and said I had done the work. She said I should be proud. I told the other patients that evening in the common room. Most of them congratulated me with practiced sincerity. A few seemed envious. One woman, older, with deep lines around her mouth, told me to make sure I actually left. She said sometimes the paperwork took longer than expected. I assured her it would be fine. I had been in the ward for 4 months. I had followed every guideline, attended every session, taken every medication without complaint. I had earned my release. The next morning I checked the large whiteboard in the hallway near the nurses' station. It was a census board listing all current residents by room number, name, and projected length of stay. My name had always been there, under the column labeled long term. I expected it to be gone or at least moved to the pending discharge section, but it was still there, highlighted in yellow, with no notation of change. I asked the nurse on duty about it. She glanced at the board, then at her tablet. She said the board was updated manually and sometimes lagged behind the system. She said I should not worry about it. I tried not to. I spent the day imagining my life outside the ward. I thought about my apartment, my job, my routines. I thought about sleeping in my own bed, cooking my own meals, walking down streets without supervision. The fantasy was so vivid it felt almost real. That night I slept deeply, dreamlessly for the first time in months. The next day I asked when I could expect the discharge paperwork. The nurse, a different one, with short red hair and a brisk efficiency, told me she would check. She disappeared into the back office and returned 20 minutes later. She said the paperwork was being finalized. She said it would likely be ready by the end of the week. I thanked her. I went to the common room and watched television with the other patients, a nature documentary about migratory birds. I found it strangely calming. The end of the week came. I approached the nurse's station and asked for an update. The nurse on duty looked at me blankly. I reminded her about my discharge. She typed something into her computer, scrolling through what I assumed were patient records. She said she did not see any discharge orders for me. I told her my psychiatrist had approved it. She said she would follow up. I returned to my room, uneasy but still hopeful. That evening, I attended group therapy. The facilitator asked how everyone was doing. I said I was looking forward to my discharge. She smiled and nodded. Another patient asked when I was leaving. I said I was waiting for the paperwork. The facilitator said that was exciting. She said she hoped the transition went smoothly. I said I hoped so too. The following Monday, I met with my psychiatrist again. I asked about the delay. She pulled up my file on her computer and frowned. She said the discharge orders had been submitted, but there had been an administrative hold. She said it was likely a clerical issue. She said she would contact the unit supervisor to expedite the process. I asked how long it would take. She said it should not be more than a few days. A few days passed. Then a week. I continued to attend sessions, take medications, and participate in activities. Staff treated me the same as always, but the discharge did not come. I checked the census board every day. My name remained in the long-term column, highlighted in yellow. I asked about it repeatedly. I was told the system was being updated. I was told the hold would be lifted soon. I was told to be patient. I began to notice something strange. Each night after the final medication round, I would return to my room and find a new progress note slipped under my door. The notes were printed on standard hospital letterhead, dated with the current day and signed by various members of the treatment team. They documented my behavior, my mood, my participation in therapy. But the language was not reflective of someone preparing to leave. The notes described ongoing treatment goals, continued monitoring, and plans for further intervention. They were written as though my discharge had never been approved. I brought the notes to my next session with the psychiatrist. I laid them on the desk between us and asked her to explain. She read through them slowly, her expression unreadable. Then she said the notes were routine documentation. She said they were required regardless of discharge status. I pointed out that the notes described long-term treatment plans. She said that was standard protocol. She said it did not mean my discharge was being reconsidered, but her voice lacked conviction. I asked to speak with the unit supervisor. The meeting was scheduled for the following week. When I sat down across from her in the small conference room, I explained the situation, the approved discharge, the administrative hold, the continuing progress notes. She listened without interrupting. When I finished, she opened a folder and pulled out a printed document. She said the treatment team had reviewed my case again. She said there were concerns about my readiness for independent living. I asked what concerns. She said the concerns were documented in the progress notes. I said the progress notes described someone who was stable and compliant. She said stability within the ward did not always translate to stability outside it. I asked if my discharge was being denied. She said it was not being denied. She said it was being deferred pending further evaluation. I asked how long the evaluation would take. She said it depended on my progress. I told her I had already made progress. She said the team needed to be certain. The days continued. I attended group therapy, where other patients came and went. I watched as new residents arrived and long-term residents were discharged, but my name remained on the census board, unchanged. The progress notes continued to appear under my door each night, documenting a version of my treatment that extended indefinitely into the future. I stopped asking about the discharge. It seemed pointless. The ward had absorbed me into its routine. The structure, the schedules, the monitored interactions, they had become my reality. I began to forget what it felt like to plan for the future. I began to forget what it felt like to believe that leaving was possible. One evening, I sat in the common room and stared at the television. Another nature documentary, this one about animals in captivity. The narrator explained how some species, when held in controlled environments for too long, lost the ability to survive in the wild. They became dependent on the structure, the predictability, the safety of the enclosure. Even when released, they often returned, or they failed to adapt, or they simply did not leave at all. I thought about the census board. I thought about the progress notes. I thought about the discharge that had been approved but never finalized. I thought about the version of me that existed in the documentation, the long-term resident whose treatment continued, whose monitoring persisted, whose release was always pending but never imminent. And I wondered if the discharge had ever been real, or if it had been another part of the routine, another procedure to document, another way to measure progress that would never result in departure. I wondered if the ward released anyone at all, or if release was simply a concept, a goal perpetually deferred, a promise made to justify the continuation of treatment. I wondered if I would ever find out, and whether in the end, I even wanted to. Story 5. The involuntary hold with no expiration date. The involuntary hold was explained to me by a legal advocate I had never met before. He sat across from me in a small consultation room, a manila folder open on the table between us. He said the hold had been initiated following a psychiatric evaluation that determined I posed a risk to myself. He said the hold was for 72 hours, renewable upon review by the treatment team. He said it was a standard procedure. He asked if I understood. I told him I did not. I told him I had not posed a risk to anyone. He said the evaluation indicated otherwise. He said the hold was in my best interest. The first 72 hours passed slowly. I was confined to the unit with limited privileges. I could not leave the floor. I could not make unsupervised phone calls. I could not attend activities that required tools or equipment. I was assessed 3 times a day by rotating staff members who asked the same questions. Did I feel safe? Did I have thoughts of self-harm? Did I understand why I was being held? I answered each time with the same calm, measured responses. I felt safe. I had no thoughts of self-harm. I understood the procedure, but I believed it was unnecessary. On the 3rd day, I expected to be informed of the hold's expiration. I waited for a staff member to tell me I was free to transition to voluntary status or to prepare for discharge. Instead, a nurse I had not seen before entered my room and handed me a printed document. She said the hold had been renewed for another 72 hours. I asked why. She said the treatment team had determined that further observation was required. I asked when the decision had been made. She said it had been documented during the overnight review. I told her I had been asleep during the overnight review. She said the review process did not require my presence. I read the document carefully. It cited behaviors observed during the previous 72 hours. Agitation, refusal to engage with staff, verbal expressions of distress. I told the nurse that none of those things had occurred. She said the observations were documented in my chart. I asked to see the chart. She said I would need to submit a formal request. I submitted the request immediately. It took 5 days to process. When I was finally allowed to review the chart, I sat with the same legal advocate in the same consultation room. He opened the file and began reading aloud. The entries described incidents I did not remember. On the first night of the hold, I had allegedly paced my room for 3 hours, refusing to sleep despite multiple interventions. On the second day, I had refused breakfast and became verbally combative when staff attempted to check my vital signs. On the 3rd day, I had expressed suicidal ideation during a one-on-one session with a social worker. I interrupted the advocate. I told him I had slept through the first night. I told him I had eaten breakfast without issue. I told him I had never met with a social worker. He looked at me for a long moment, then said the documentation was signed and time-stamped. He said it was considered legally binding. I asked who had observed these behaviors. He flipped through the pages and listed several names: nurses, orderlies, a psychiatric resident. None of the names were familiar. I asked if I could speak with them. He said that would not be possible. He said staff members were not required to participate in patient disputes over clinical documentation. I told him it was not a dispute. I told him the documentation was false. He said that was for the treatment team to determine. The hold was renewed again and again. Each renewal came with new documentation describing behaviors that contradicted my memory. I began to suspect the documentation was generated automatically, filled in with generic observations that justified continued detention. I began to track time more carefully. I marked each day on the back of a paper towel I kept hidden beneath my mattress. I counted the renewals. 7, then 10, then 15. I requested a hearing. The advocate said I was entitled to one, but that it would take time to schedule. He said the backlog was significant. He said I should expect a wait of several weeks. I asked what I was supposed to do in the meantime. He said I should continue to cooperate with treatment. He said cooperation would strengthen my case. I cooperated. I attended every session. I took every medication. I answered every question with calm, measured honesty. But the documentation continued to describe someone else, a patient who resisted treatment, who exhibited signs of instability, who posed an ongoing risk. The version of me in the chart bore no resemblance to the person I believed myself to be. One night, unable to sleep, I noticed something strange about the clock mounted on the wall of my room. It displayed the time as 2:17 in the morning. I closed my eyes and counted to 60. When I opened them again, the clock still read 2:17. I assumed it was broken. But when I checked the clock in the hallway the next morning, it displayed a different time than the one in my room. I asked a nurse about it. She said the clocks were synchronized with the hospital system. She said if there was a discrepancy, it was likely a malfunction. I began to notice other discrepancies. The medication rounds sometimes occurred at irregular intervals. The shift changes did not always align with the posted schedule. The meals arrived at times that did not correspond to breakfast, lunch, or dinner. I asked other patients if they had noticed the same inconsistencies. Most seemed unconcerned. One man said time was different in the ward. He said it did not follow the same rules. I asked my psychiatrist if the hold would ever expire. She said the hold would be lifted when the treatment team determined I was no longer a risk. I asked how they would make that determination. She said it was based on observable progress and clinical judgment. I asked what observable progress looked like. She said it varied by patient. I asked if there were specific criteria. She said the criteria were individualized. I asked if my progress was being measured against any standard. She said the standard was my own baseline. I asked what my baseline was. She said it was established during my initial evaluation. I asked if I could see that evaluation. She said she would look into it. She never brought it up again. The hearing was finally scheduled. I was escorted to a small conference room where 3 individuals sat behind a long table. A lawyer, a hospital administrator, and a psychiatrist I had never met. The legal advocate accompanied me. The hearing lasted 20 minutes. The hospital's lawyer presented the documentation, reading aloud from the chart. The behaviors were described in clinical language, detached and authoritative. I was given an opportunity to respond. I said the documentation was inaccurate. I said I had not exhibited the behaviors described. The psychiatrist I had never met asked if I remembered exhibiting those behaviors. I said I did not. He made a note. The administrator asked if I understood why the hold had been initiated. I said I understood the procedure, but I believed it was unjustified. She made a note. The lawyer thanked me for my time. The decision was issued 3 days later. The hold was upheld. The reasoning cited the documented behaviors, the clinical judgment of the treatment team, and the need for continued observation. I asked the advocate if there was an appeal process. He said there was, but that it would take months. He said the likelihood of success was low. He said I should focus on cooperating with treatment. I stopped keeping track of the renewals after that. The hold became permanent in practice, if not in name. The ward became my reality. The routine, the documentation, the observations, they were constants. I no longer asked when I would be released. I no longer believed there was a timeline. One night I stared at the clock on my wall. It read 3:41 in the morning. I counted to 60. It still read 3:41. I counted again. Still 3:41. I realized the clock had not moved in hours, maybe days, maybe longer. Time in the ward was not measured by clocks. It was measured by renewals, by documentation, by the perpetual accumulation of behaviors I had not performed. And I understood finally that the hold had no expiration date. It had never been designed to expire. It existed to justify my presence, and my presence justified the hold. The loop was perfect, self-sustaining, infinite. I wondered if anyone would notice if I stopped existing altogether, or if the documentation would continue recording behaviors, observations, and incidents, long after there was anyone left to observe. Story 6. The patient who attended his own case conference. Case conferences were conducted weekly in a small meeting room on the second floor. I knew this because I could hear the muffled voices filtering through the walls during the late afternoon hours. The meetings were closed to patients. Staff would gather to discuss treatment plans, progress reports, and discharge recommendations. I had never been invited. I had been told that my case was reviewed regularly, but that the discussions were confidential. I accepted this. It seemed reasonable. The change began on a Tuesday. I was walking past the meeting room on my way back from recreational therapy when I noticed the door was slightly ajar. Voices drifted into the hallway, calm, professional, clinical. I glanced inside without thinking and saw a long table surrounded by staff members. A psychiatrist I recognized sat at the head. A social worker flipped through a thick binder. 2 nurses consulted a shared tablet. I moved to continue walking, but one of the nurses looked up and made eye contact. She smiled briefly and gestured for me to enter. I hesitated. She repeated the gesture more insistently. I stepped inside. No one questioned my presence. The psychiatrist glanced at me, nodded, and continued speaking. She was reviewing a case, a patient whose name I did not immediately recognize. She described the patient's history, their symptoms, their response to medication. The social worker interjected with updates on family contact and housing arrangements. The nurses added observations about behavior and compliance. I stood near the door, unsure of where to sit or whether I should leave. After a moment, the social worker gestured to an empty chair at the far end of the table. I sat. The discussion continued. The psychiatrist asked questions. The staff members responded. I listened quietly, trying to understand why I had been allowed into the room. Eventually, the psychiatrist said the patient's name again, and I recognized it. It was mine. They were discussing me, my history, my symptoms, my response to medication. I looked around the table, expecting someone to acknowledge the strangeness of the situation, but no one did. The social worker flipped to a new page in her binder and read aloud from a progress note. She described behaviors I vaguely remembered performing: attending a group session, eating breakfast in the cafeteria, walking in the courtyard. The details were accurate but strangely impersonal, as though she were describing someone she had observed from a distance. The psychiatrist asked if there had been any incidents of concern. One of the nurses said there had been a moment of hesitation during medication distribution, but that it had resolved without intervention. I did not remember hesitating. I had taken my medication every day without question, but I did not interrupt. I sat quietly and listened as they debated whether the hesitation indicated ambivalence about treatment or was simply a momentary distraction. They concluded it was worth monitoring. The social worker moved on to the next topic, my prognosis. She said I had shown consistent progress over the past several weeks. She said I was engaging appropriately with therapy and adhering to the treatment plan. The psychiatrist agreed, but noted that there were still concerns about my long-term stability. She said I would benefit from continued observation in a structured environment. One of the nurses asked how long the observation should continue. The psychiatrist said it depended on several factors. She said they would reassess in another month. I wanted to speak. I wanted to ask why I was being discussed as though I were not present. But the words caught in my throat. The conversation moved forward without pause. The psychiatrist asked if there were any additional comments. The social worker mentioned that my family had not responded to recent outreach attempts. She said it was unclear whether they were aware of my admission. I almost corrected her. I had no family to contact. But I remained silent. The psychiatrist made a note and said they would continue to attempt contact. The meeting concluded. The staff members gathered their materials and stood. The psychiatrist thanked everyone for their input. I stood as well, expecting someone to acknowledge me, to explain why I had been present, to ask if I had any questions. But they filed out of the room without a word. I was left alone, staring at the empty table, the abandoned binders, the tablets now dark and silent. I attended the next case conference the following week. This time I entered the room without hesitation. The staff members were already seated. The psychiatrist was reviewing another case. I took the same chair at the far end of the table. No one greeted me. No one asked why I was there. I listened as they discussed a different patient, a woman who had been on the ward for 6 months. They debated her medication regimen, her participation in therapy, her readiness for discharge. The conversation was thorough, measured, detached. When they finished, the psychiatrist transitioned to the next case. Mine. She described my recent behavior in the same clinical tone she had used for the woman. She said I had attended all scheduled sessions. She said I had demonstrated appropriate affect. She said there had been no incidents of concern. The social worker added that my engagement with staff had been cooperative. One of the nurses noted that I had been sleeping well. The psychiatrist asked if there were any reservations about reducing my level of observation. The staff members exchanged glances. The social worker said she believed I was stable, but that it was premature to make changes. The others agreed. I sat through the discussion in silence. I listened as they outlined a treatment plan that extended another 6 weeks. I listened as they debated whether I should be transferred to a different unit or remain where I was. I listened as they discussed my future as though I were an object to be managed rather than a person capable of making decisions. When the meeting ended, I stood and left with the others. None of them spoke to me. None of them acknowledged that I had been present. The pattern continued. Each week I attended the case conference. Each week my case was reviewed. Each week I sat at the far end of the table and listened to the staff discuss my progress, my setbacks, my prognosis. The discussions became longer, more detailed. The psychiatrist began to raise questions about outcomes that seemed increasingly distant. My reintegration into the community, my ability to maintain employment, my capacity for independent living. The conversations were always framed in terms of what I would need, what I should work toward, what would be best for me. But I was never asked. I was never consulted. I began to notice something disturbing. The discussions sometimes referenced events that had not yet occurred. The social worker would mention a group session I had attended that afternoon, but the meeting was taking place in the morning. One of the nurses would describe my behavior during the evening medication round, but it was still midday. The psychiatrist would reference progress notes dated for the following week. At first, I assumed I was misunderstanding. But the discrepancies became too frequent, too specific. During one conference, the psychiatrist described an incident in which I had become agitated during a one-on-one session with a therapist. She said the incident had occurred 3 days prior. I had not met with a therapist 3 days prior. I had not met with a therapist at all that week. I wanted to interrupt, to correct the record, but I could not bring myself to speak. The words felt trapped, as though speaking would shatter some fragile pretense that allowed me to remain in the room. The conferences became increasingly surreal. The staff discussed hypothetical scenarios. What would happen if I refused medication, if I became violent, if I attempted to leave the ward? They discussed contingencies, interventions, escalations. They discussed outcomes that required my cooperation long after recovery, outcomes that assumed I would remain under their care indefinitely. They discussed versions of me that existed only in projections, in documented possibilities, in futures that had not yet been written but were already being planned. I attended every conference. I sat in the same chair. I listened to the same voices. I watched as they constructed a narrative of my life. a life that existed only within the confines of the ward, only within the structure of treatment, only within the framework of their observations. I was present, but I was not included. I was the subject of every discussion, but I had no voice in any decision. And I began to understand that the conferences were not about treating me, they were about maintaining me. The discussions were not about my recovery, they were about the continuation of my case. The outcomes they debated were not milestones toward discharge. They were justifications for continued observation, for extended stays, for perpetual management. I wondered if I would ever stop attending the conferences, or if I would sit at that table for the rest of my life, listening to strangers plan my future, dissecting my past, documenting my present, while I remained silent, invisible, a presence without agency. And I wondered if anyone in that room even remembered I was there. Story 7, the disoriented transfer with familiar restraints. The transfer was explained to me by a nurse I had seen only once before. She said there had been an incident during the previous night, an episode of disorientation in which I had been found wandering the hallway, unable to recall my name or location. She said the treatment team had decided it would be best to move me to a unit better equipped to handle my needs. I told her I did not remember any incident. She said that was precisely the concern. She said disorientation often involved memory loss. She said the transfer was for my safety. I was escorted to the new unit by 2 orderlies. The hallways were identical to the ones I had just left. Pale green walls, fluorescent lighting, the faint smell of disinfectant. The new unit was on a different floor, but the layout was familiar. The nurses' station in the center, the patient rooms along the perimeter. The common area with its bolted furniture and mounted television. I was shown to room 9A. The orderlies unlocked the door and gestured for me to enter. I stepped inside. The room was small, sterile, and unremarkable. Except for the restraints. They were attached to the bed frame. 4 leather cuffs, 1 for each limb. The straps were coiled neatly, the buckles polished and ready. I turned to ask the orderlies why the restraints were present, but they had already left, the door clicking shut behind them. I stood in the center of the room and stared at the bed. I had never been restrained. I had never posed a physical threat. I had never exhibited behavior that required that level of intervention. But the restraints were there, waiting, as though their use had already been determined. A nurse entered shortly after. She was older, with graying hair pulled into a tight bun and a clipboard tucked under her arm. She introduced herself as Claire. She said she would be conducting an intake assessment. I told her I had already been assessed at the previous unit. She said this was a new unit with different protocols. She asked me to sit on the bed. I did. She asked a series of questions. My name, my date of birth, the current date, the reason for my admission. I answered each one correctly. She made notes on her clipboard without comment. Then she asked if I remembered the incident from the previous night. I told her I did not. She asked if I remembered wandering the hallway. I told her I did not. She asked if I had experienced confusion or disorientation in the past. I told her I had not. She made more notes. She asked if I understood why I had been transferred. I said I understood the explanation I had been given, but that it did not align with my memory. She nodded slowly and said, "Memory disturbances were common in cases like mine." I asked what she meant by cases like mine. She said she could not discuss specifics without consulting the treatment team. She left the room without another word. The restraints remained. No one mentioned them. No one removed them. They simply existed, a constant presence at the periphery of my awareness. I tried to ignore them. I attended the scheduled activities, group therapy, recreational time, meals in the cafeteria. Staff interacted with me politely, but with a certain distance, as though I were fragile or unpredictable. Other patients avoided me. I did not understand why until I overheard a conversation in the common room. Two men were speaking in low voices. One of them said I had been transferred because I was a safety risk. The other asked what I had done. The first man said he did not know the details, but that I had required restraints during the incident. I approached them and told them there had been no incident. They looked at me with a mixture of pity and discomfort. One of them said he was sure it would be sorted out. The other said nothing. I returned to my room and sat on the edge of the bed, careful to avoid the restraints. That night I woke to the sound of voices outside my door. I could not make out the words, but the tone was urgent. I heard footsteps. The door opened. Two nurses entered, followed by an orderly. One of the nurses, Claire, approached the bed and told me to remain calm. I asked what was happening. She said I had been exhibiting signs of distress. I told her I had been asleep. She said that was part of the concern. She gestured to the orderly, who moved to the side of the bed and reached for one of the restraints. I pulled my arm away and asked why they were restraining me. Claire said it was a precautionary measure. She said I had a history of disorientation during sleep. I told her I had no such history. The orderly secured the restraint around my wrist, then the other wrist, then my ankles. I did not resist. I was too confused, too disoriented by the sudden intrusion. When they finished, Claire checked the tightness of each cuff and made a note on her clipboard. She told me to try to rest. They left the room, the door locked behind them. I lay in the dark, my limbs immobilized, my mind racing. I tried to remember the incident they kept referencing. I tried to recall wandering the hallway, losing track of my name, exhibiting distress during sleep. But there was nothing. My memory was clear, continuous, unbroken. Yet the restraints suggested otherwise. I was released the next morning. Claire entered the room, unfastened the cuffs, and asked how I had slept. I told her I had not slept. She made a note. She asked if I remembered being restrained. I told her I remembered everything. She asked if I understood why the restraints had been necessary. I told her I did not. She said the treatment team would review the incident during rounds. She said I should speak with my psychiatrist if I had further questions. I met with the psychiatrist that afternoon. She was a different person than the one I had worked with at the previous unit, a younger woman with a calm, measured demeanor. She asked how I was adjusting to the new environment. I told her I was confused. I told her I did not understand why I had been transferred or why I had been restrained. She opened a file on her desk and reviewed several pages. She said the transfer had been initiated following a documented episode of acute disorientation. She said the restraints had been used as a safety measure during a period of agitation. I told her I had not been agitated. She said the documentation indicated otherwise. She said it was not uncommon for patients to have incomplete memories of such episodes. I asked to see the documentation. She hesitated, then turned the file toward me. The report described an incident that had occurred at 2:30 in the morning. It said I had been found in the hallway, unresponsive to verbal prompts, attempting to open locked doors. It said I had become physically resistive when staff attempted to redirect me. It said I had been escorted back to my room and placed in restraints to prevent further harm. The report was signed by 2 nurses and an orderly. None of the names were familiar. I told the psychiatrist the report was false. I told her I had been asleep in my bed at 2:30 in the morning. She asked if I was certain. I said I was. She asked if I had any history of sleepwalking or nocturnal confusion. I said I did not. She made a note and said she would discuss the matter with the treatment team. She said in the meantime I should focus on engaging with therapy and following the unit's protocols. She said cooperation would help clarify the situation. The restraints were used again that night, and the night after. Each time, I was told it was a precautionary measure. Each time, I was released in the morning with no explanation beyond vague references to safety and documentation. I stopped protesting. I stopped asking questions. The restraints became routine. I began to notice that the restraints fit perfectly. The cuffs were adjusted to my wrists and ankles with a precision that suggested prior measurement. The buckles fastened smoothly without need for adjustment. The straps were neither too tight nor too loose. They had been prepared specifically for me long before I arrived at the unit, and I realized that the transfer had not been a response to an incident. The incident had been created to justify the transfer. The disorientation had been documented to explain the restraints. The restraints had been waiting because my arrival had been planned. The confusion was not mine. It was theirs. They had confused me with the patient they had been expecting, the one who wandered, who resisted, who required restraints. And I had been moved into his place. I wondered if that patient had ever existed, or if the restraints had been waiting all along, empty and ready for anyone they could be used on. Story 8. The patient listed as environmental risk. The classification appeared on a printed form left briefly unattended at the nurse's station. I was passing by on my way to the common room when I noticed my name. It was listed under a heading I did not recognize, Environmental Risk Assessment. I stopped and glanced at the page. My name was there, followed by a series of codes and notations I could not decipher. Beside my name was a single word, active. I did not understand what it meant. I asked the nurse on duty. She picked up the form quickly, almost defensively, and told me it was internal documentation. She said it was nothing I needed to worry about. But I did worry. The phrase stayed with me. Environmental risk. I turned it over in my mind during group therapy, during meals, during the long stretches of empty time between scheduled activities. I asked other patients if they had heard the term before. Most had not. One man, older with a tremor in his hands, said he had seen similar forms. He said they were used to categorize patients who posed risks to the physical environment rather than to themselves or others. I asked what that meant. He shrugged and said it was usually things like fire hazards or infection risks. He said it was nothing serious. But his tone suggested otherwise. I requested a meeting with my psychiatrist. It took 3 days to schedule. When we finally sat down together, I asked about the environmental risk classification. She looked at me with a calm, unreadable expression. She said the classification was part of the ward's safety protocol. She said it was used to identify patients whose presence required adjustments to the physical environment. I asked what adjustments. She said it varied depending on the individual case. I asked what my case involved. She said she would need to review the documentation. She said she would get back to me. She did not get back to me. But I began to notice changes. The lighting in my room was adjusted. The overhead fixture, which had always been a harsh fluorescent white, was replaced with a softer, warmer bulb. I asked a maintenance worker why the change had been made. He said it was part of a routine upgrade. But my room was the only one on the unit with the new lighting. I checked. The ventilation changed as well. The air in my room, which had always been still and slightly stale, began to circulate more actively. I could feel it when I lay on the bed, a faint current, cool and constant. I asked a nurse if the ventilation system had been repaired. She said she was not aware of any repairs. She said the system was functioning normally, but other patients complained that their rooms were too warm. Mine was not. The changes continued. The window in my room was fitted with a new shade, thick blackout material that blocked all external light. The thermostat was adjusted remotely. I could no longer control the temperature. The door was fitted with a new sensor, a small device mounted near the frame that emitted a faint red light. I asked what the sensor was for. A staff member said it was part of an updated monitoring system. I asked what it monitored. He said it tracked room occupancy. I asked why that was necessary. He did not answer. I began to feel as though the room was responding to me. The lighting dimmed when I entered and brightened when I left. The ventilation increased at night and decreased during the day. The temperature adjusted based on patterns I could not identify. It was subtle, almost imperceptible, but it was there. The room was being calibrated around my presence. I asked my psychiatrist about it during our next session. I described the changes, the lighting, the ventilation, the sensors. She listened, without interrupting. When I finished, she asked if the changes were bothering me. I told her they were unsettling. She asked why. I said it felt as though the room was monitoring me in ways I did not understand. She made a note and said the adjustments were likely part of the environmental risk protocol. I asked her to explain the protocol. She said it was designed to minimize potential hazards. I asked what hazards I posed. She said the assessment was based on multiple factors. She said she could not discuss the specifics without compromising the integrity of the evaluation. I began to keep track of the changes. I noticed that the lighting in the hallway outside my room adjusted when I walked past. The brightness increased slightly, then returned to normal once I had passed. The ventilation in the common room shifted when I entered, directing airflow away from where I sat. The thermostat in the cafeteria seemed to respond to my proximity. Temperatures dropping slightly when I was present, rising when I left. Other patients began to notice as well. One woman asked me if I was cold. She said the temperature always seemed to drop when I was nearby. I told her I had noticed the same thing. She moved to a different table. Another patient asked if I had complained about the lighting. He said the staff had been adjusting the fixtures ever since I arrived. I told him I had not complained. He said it was strange. He stopped sitting near me during group therapy. The isolation became more pronounced. Staff began to interact with me differently. They maintained a certain distance, both physical and conversational. They addressed me politely but briefly, as though prolonged interaction carried some undefined risk. Maintenance logs appeared on clipboards at the nurses' station, listing adjustments made to lighting, ventilation, and temperature, all corresponding to my location on the unit. I requested another meeting with my psychiatrist. This time I asked directly what risk I posed to the environment. She set down her pen and looked at me for a long moment. She said the classification was not a reflection of behavior. She said it was a reflection of presence. I asked her to clarify. She said that some patients required environmental modifications to maintain stability. Not their own stability, but the stability of the space they occupied. I asked if that meant I was somehow altering the environment. She said the relationship was more complex than that. She said the environment and the patient existed in a feedback loop. She said the modifications were meant to maintain equilibrium. I asked what would happen if the equilibrium was disrupted. She said it depended on the severity of the disruption. She said it could result in equipment malfunction, structural instability, or other unforeseen complications. I asked if she was suggesting I was causing equipment to malfunction. She said she was not suggesting anything. She said the protocol was precautionary. I left the meeting more confused than before. I returned to my room and lay on the bed staring at the ceiling. The lighting dimmed automatically. The ventilation adjusted. The temperature dropped by a degree, then stabilized. I wondered if the room was responding to me, or if I was responding to the room. I wondered if the modifications were meant to protect the environment from me, or to protect me from the environment. I began to test the boundaries. I moved through the unit at irregular times, observing the way the lighting and temperature shifted. I spent extended periods in the common room, noting the adjustments in airflow. I stood near the nurse's station and watched as staff members glanced at monitors I could not see. I asked what they were monitoring. They said it was routine. I asked if it was related to my classification. They did not answer. One evening, I overheard a conversation between two maintenance workers. They were discussing a repair in the ventilation system. One of them said the system had been malfunctioning in the East Wing. The other said it was because of the environmental risk patient. He said the sensors were overcompensating. The first worker asked if they were going to relocate the patient. The second said it was not his decision. They noticed me and stopped talking. I returned to my room and sat on the edge of the bed. I thought about the classification. I thought about the adjustments, the sensors, the maintenance logs. I thought about the way the environment responded to my presence, as though I were a variable that needed to be controlled, a factor that disrupted the system simply by existing. And I realized that the classification was not about what I might do. It was about what I was. The risk was not an action, it was an attribute. The environment was being modified not to prevent harm, but to accommodate something inherent in my presence. Something that could not be treated, could not be corrected, could not be removed. I wondered what would happen if the modifications failed, if the equilibrium could not be maintained, if the system could not compensate for the variable I represented. I wondered if they would remove me, or if they would simply keep adjusting, modifying, calibrating, forever trying to contain a risk they could not define but could not ignore.